Hello. Okay. So welcome all. So Fora, can you put me on the main screen? Has Fora disappeared? Can you hear me? You can hear me. Okay.
Yes.
Okay. Okay. Welcome. Thank you, Fora, for creating the video that you just saw. And the forum has been ongoing for several years. And welcome all to this seminar. We have two distinguished speakers today with the theme of how to use the modern imaging in the detection of gastric neoplasm. So allow me to introduce the first speaker, Dr. Tomohisa Kadota from National Cancer Center East. I was just reading on his publications. He's an expert endoscopist on ESD and modern imaging, especially in the esophagus. So he's going to speak to us on a trial that was published, multi-center Japanese style trial published last year in American Journal of Gastroenterology, plus other issues on how to detect gastric neoplasms. Welcome, Dr. Kadota.
Thank you. Can I share? Can you see?
Yes, we can see.
Okay. Good afternoon, everyone. Thank you very much for the kind introduction. My name is Tomohisa Kadota from National Cancer Center Hospital East, Kashiwa, Japan. It is a great honor to have the opportunity to speak at this meeting. Today, I'd like to talk about detection of gastric neoplasm with particular focus on the role of imaging-enhanced endoscopy, especially third-generation NBI. NBI is firstly developed with EBIS Lucera spectrum in 2006. And since then, EBIS Lucera Elite with second-generation NBI was developed, and the efficacy of NBI has been reported in various areas. Recently, the new endoscopic system, EBIS X1 and third-generation NBI and TXI was developed. So today, I'd like to talk about NBI, focus on the detection for gastric neoplasm. Here is the outline my presentation. First, I will briefly discuss the rationale for gastric surveillance after endoscopic dissection. Although surveillance is recommended worldwide, the optimal imaging modality has not yet been established. Next, we will review the current evidence regarding NBI, including its established role in esophageal and head and neck cancers, as well as in quantitative diagnosis of gastric cancers. Finally, I will present the results of our randomized phase 2 trial, comparing WLI, third-generation NBI and TXI, and introduce our ongoing phase 3 trial. Let me begin with the current situation of gastric cancer in Japan. As shown on the left, the age-adjusted incidence of gastric cancer has steadily declined over the past several decades. This decline is mainly attributed to a reduced prevalence of Helicobacter pylori infection and widespread eradication therapy. However, despite the decline in the case of gastric cancer, the number of endoscopic dissection has not decreased, but has remained flat, as shown on the graph to the right. This probably reflects the widespread use of screening endoscopy, the expansion of indication for ESD, and advance in endoscopic techniques. As a result, we now encounter an increasing number of patients who require long-term surveillance after ESD. Following several multicenter clinical trials, the indication for ESD have expanded. However, even after curative ESD, patients remain at risk of metachronous gastric cancer because the atrophic gastritis is preserved. Is resection alone sufficient for early gastric cancer? Several large cohort studies have consistently demonstrated that metachronous cancer continues to occur over time, particularly after ESD for differentiated type gastric cancer. These findings highlight the importance of long-term endoscopic surveillance after ESD. More recently, the value of annual surveillance for high-risk patients was demonstrated. Even after an intensive endoscopy using both WLI and NBEI imaging, 2.6 patients were diagnosed with a newly early gastric cancer at the one-year surveillance examination. These findings support the recommendation for annual surveillance endoscopy, even after intensive index endoscopy. These clinical findings are reflected in current guidelines. Regular endoscopic surveillance, generally once or twice a year, is recommended after ESD because patients remain at risk of metachronous gastric cancer. Helicobacter pylori eradication is recommended, although it does not completely eliminate the risk of metachronous gastric cancer. No guideline recommends a specific IEE modality for surveillance. While WLI is the current standard, image-enhanced endoscopy has advanced significantly. Let's review the current evidence for NBI. Before focus on gastric observation, I'll briefly review the established role of NBI in detecting esophageal and head and neck cancers. At first, I'd like to introduce a randomized control trial conducted about 15 years ago by Dr. Muto. This study compares WLI with NBI for detection of superficial head and neck cancer and esophageal squamous cell carcinoma in patients with current or previous ESCC. A back-to-back design was used with EBIS Lucera spectrum with first-generation NBI. Patients underwent WLI observation followed by NBI or NBI observation followed by WLI. The result is striking. In the head and neck region, the detection rate was 8% in WLI, but 100% in NBI arm. Similarly, in esophagus, the detection rate was 55% in WLI and 97% in NBI arms. Since then, NBI has become the standard imaging modality for screening superficial squamous cell carcinoma in these organs. In gastric cancer, however, the role of NBI is somewhat different. Rather than lesion detection, NBI is mainly used for quantitative diagnosis. According to Mr. G algorithm, gastric cancer is diagnosed based on the presence of demarcation line and or with an irregular microvascular pattern or irregular microsurface pattern. This algorithm allows accurate differentiation between cancer and non-cancer. Therefore, magnifying NBI has become the standard modality for the optimal diagnosis of gastric cancer. However, whether NBI also improves gastric lesion detection has remained unclear. To address this question, Yoshida and college conducted a large multicenter phase 3 randomized control trial. More than 4,000 500 patients with current or previous gastric or esophageal cancer undergoing surveillance endoscopy or preoperative endoscopy were enrolled. Using the second generation NBI system, EBIS Lucera Elite, patients were randomized assigned to undergo either WLI observation followed by NBI or NBI observation followed by WLI in back-to-back design. The primary endpoint was the detection rate of newly diagnosed early gastric cancer. Here is the main result. The detection rate in WLI and the second generation NBI arms were 1.9% and 2.3%. Unfortunately, second generation NBI did not demonstrate superiority over WLI for the detection of early gastric cancer. And the detection rate of early gastric cancer and adenoma were higher with second generation NBI, but the difference were not significant. In addition, approximately 25% of lesions were missed on the first observation in both groups. Therefore, second generation NBI did not improve gastric cancer detection compared with WLI. Although primary endpoint was not met, this study provides several important insights. Second generation NBI overcomes the major limitation of first generation NBI by improving image brightness. However, improved brightness alone was not sufficient to improve the detection of early gastric cancer. Importantly, approximately 25% of gastric cancers were detected only during the second observation, indicating that number of patients, number of lesions were still being overlooked during the first observation. These findings suggest that there was still room for improvement and that even brighter image-enhanced endoscopy may further improve early gastric cancer detection. The introduction of EBIS X1 system in 2020 brought about a significant improvement in both WLI and NBI and the newly developed texture and color enhanced imaging, TXI. These technological advances provided an opportunity to re-evaluate the optimal imaging modality. Therefore, we conducted a randomized phase 2 trial to identify the most promising imaging modality for a subsequent randomized phase 3 trial. This was an exploratory multicenter randomized 3-arm phase 2 trial. Patients with current or previous gastric or esophageal cancer undergoing surveillance endoscopy or preoperative endoscopy were randomizedly assigned to WLI, third generation NBI, or TXI. The primary endpoint was detection rate of new gastric neoplasm, including early gastric cancer and adenoma. The decision criteria to determine the most promising modality is defined as one with a higher gastric neoplasm detection rate between 3G NBI or TXI, and one that outperforms WLI by more than 1% in terms of detection rate. The sample size was set to 300 per arm. Patients' characteristics were well balanced among 3 groups. About 60% of patients underwent surveillance endoscopy after gastric ESD, while about 20% underwent preoperative endoscopy for gastric neoplasm. In addition, approximately 55% had undergone Helicobacter pylori eradication and more than 60% had open type atrophic gastritis. Here is a representative case. This is type 02C early gastric cancer on the greater curvature antrum. On the WLI, the lesion appears a slightly reddish superficial depression. With third generation NBI, it is clearly recognized as well demarcated brownish area. With TXI, the reddish ochre color is enhanced compared with WLI. Which modality do you prefer for detecting this lesion? Okay. Now let me present this study result. The GN detection rate in WLI and 3 third generation NBI and TXY were 5.6%, 7.3%, and 5.0%. Among three modalities, third generation NBI achieved the highest detection rate, so the predefined decision criteria identified third generation NBI as the most promising imaging modality. So third generation NBI was selected for further evaluation in the phase 3 trial. And as for early gastric cancer, third generation NBI shows the highest detection rate among three groups. In addition, approximately 15 of the lesions were missed on the first observation in both groups. Although the observation time was longest in third generation NBI, the difference was relatively small. Based on these results, third generation NBI was selected for a large-scale phase 3 randomized controlled trial. This trial is currently underway to evaluate the superiority of third generation NBI over WLI, and its results are awaited. Now, let me briefly summarize the clinical implication of our findings. First, third generation NBI achieved the highest gastric neoplasm detection rate and was selected for evaluation in an ongoing phase 3 trial. The improved brightness and image quality of EBCX1 system may have contributed to this favorable performance. Regarding to TXI, its performance may have influenced by the learning curve, enhanced background gastritis, and the lack of established optimal imaging mode. Importantly, this study provides the first prospective evidence for the use of TXI in gastric neoplasm detection. TXI may overemphasize inflammatory change, potentially reducing the visibility of gastric neoplasm. Finally, an ongoing multi-center phase 3 trial will determine whether third generation NBI offers a true clinical benefit over WLI for gastric detection. If the superiority of third generation NBI is confirmed, it may establish a new standard imaging modality for detection in high-risk patients. Finally, I would like to share my current approach to gastric observation. In routine practice, I still perform observation mainly with WLI. However, when I encounter severe atrophic gastritis or extensive intestinal metaplasia, I add the second observation using NBI. In particular, if there are multiple depressed area in the antrum, I carefully examine each one with NBI. Although this approach has not yet been validated, I believe it helps me avoid overlooking gastric neoplasm. And we would like to await the result of ongoing phase 3 trial. Thank you for your kind attention.
Thank you very much. An excellent talk. I continue to be very impressed by the Japanese multi-center studies, large numbers, looking at very, very small difference. So we will reserve the discussion after Louis' talk. Allow me to introduce Louis Lau, who's my colleague at the Prince of Wales Hospital. He's been recently promoted to be an associate professor. Congratulations.
Thank you.
He's going to speak to us on artificial intelligence in addition to imaging. Thank you, Louis.
Thank you, Professor Lau. So just double check you can see my screen correctly.
I think
Now it's better.
Yeah.
Now it's better, right? Okay, so good afternoon, everyone. So thanks again, Professor Lau, for the invitation to join this symposium. And also thanks again, Dr. Kadota, Noria, and James for joining the session as well. So now I'm going to talk about something beyond the imaging, because the theme today is the imaging modality. But we are living in the era of AI, so I want to touch a bit on the AI in upper GI cancer screening in this talk. So these are my disclosures. So I think we are entering the era of the next generation endoscopy. So we have heard the very nice imaging of the X1 system with the TXI or even MBI TXI functions, the new high quality imaging, which provide the good eyes of doing endoscopy. Nowadays, we also have very good hands with all sort of device or even robotics to treat the cancers or early cancers, which we are performing endoscopic surgeries. But I believe we still need a very good brain, which is to make the correct diagnosis and make the correct decision. So that's why I think AI will have a very emerging role in the coming like 5 to 10 years. The main reason is that although we all know that we learn OGD from the first day of the training, yet this is not so simple, because according to a very large scale population study from the Europe, we found that there are around 6% of upper GI cancer that are missed within 6 months to 3 years after a so-called normal EGD. That means 6 out of 100 cancers are actually missed cancers. So this is quite a alarming number. But the main problem is not only the missed cancer, is that most of the missed cancers are actually within the stage 0 or stage 1. And they are actually treatable by endoscopic resection if we can detect them in the early phase, but not after 3 years. So probably there is a very huge gap that we should pick up these early cancers as soon as possible. A very quick example is this patient was actually sent for an EGD earlier, and there was just so-called random biopsy finding something, but in fact the lesion was quite hiding behind the scope, and also you can probably only see after some sort of special maneuver. Therefore, this cancer can be easily missed if this is only done by a trainee or someone inexperienced. So I try to conclude the reasons that why we miss the early upper GI cancers. There are mainly like 5 reasons. The first reason, of course, is an incomplete examination. For example, the cancer that I just showed, we need to do a proper retrofraction and also some rotation. That means if there are some blind spots, then this can be a reason for missed cancer. Of course, the lesion factor, like if the cancer is very small or very pale, that are not so obvious, they can be missed. And of course, the awareness, knowledge, and also the endoscopist experience are also equally important. And one major point will be the fatigue from the experience, even from an experienced endoscopist as well, because we all perform a lot of endoscopy throughout the day. Probably we may have a little bit decrease in the attention span towards the end of the day. So this may be the high risk period. And actually, can we all overcome these kind of weakness by using AI as a co-pilot or assistant? So this is a question. So in the coming few slides, I want to show everyone the current landscape of the AI in the upper GI field, because we all know that the AI is rapidly developing in the colon. But how about in the upper GI? So before that, we always need to ask that what are the essential elements for a good EGD? So this was first proposed by Professor Yao, and we all know that we need to make sure we perform a complete endoscopy. That means no blind spot. And also there are ample data showing the inspection time of the EGD should be around 7 minutes, which will allow you enough time to complete the observation and also make the good photo documentation as well. And if we move forward to the examination skill, we of course need to know what are the at-risk stomach. For example, mentioned by Dr. Kadota before, those with IM or atrophic gastritis, we need to pay special attention on those cases. And of course, we need to detect lesion and then we characterize the lesions. So I will try to illustrate what are the potential roles for AI and the current data for that. So the first thing we need to know is for AI, we can help on two major, I would say, pillar. The first thing is the quality control, which we know as the CAQ. And the second thing will be the computer-aided tasks. Then it can be detection or diagnosis. So I try to go through the quality control first. So this program was jointly developed by CHK and Endovision called the Cerebral. We can see that when you are examining the EGD, the computer will then automatically register what you have been going through and give you a tick with the checkbox. And after the examination, you should be able to get an end result like this with no missing observation site. So this would probably help us to make sure that we have gone through the systemic protocol for the screening. And if we haven't, then we can go back and re-examine. So our group has also tried to evaluate this system with the standard EGD. And you can see that with the help of the AI monitoring, the completeness of the EGD is around 20% higher than the conventional group. And also the number of photo documentation is near perfect in the AI group compared to less than half in the control group. The interesting thing is overall time spent on the examination is probably the same. So that means the AI wouldn't cost you extra time to work on. So this may be quite a promising modality, especially for the new trainees, because this study also focus on the endoscopy trainees so that they are assisted to make sure that they have gone through all the key spots. Another similar study from the group of China also shows similar findings. You can see that with the quality control AI system, you can see that the inspection time is even lower in this study by around 1 minute, but the lesion detection rate is similar or even slightly higher in the AI group with an equal biopsy rate. So probably this may help to safeguard the quality for some inexperienced endoscopists. And also another group also reported about some AI-assisted auto photo documentation. That means when you have reached that particular point, the AI will try to help you to capture all the essential photos, and probably they can select the higher quality ones for you as well. So you can see that by comparing it between the endoscopist alone, the AI alone, and also the combination of both, you can obviously see that the best performance will be the combo arm. So probably it can assist us to do some better photo documentations as well, especially in the BC days. We may forget about the taking good photos. Definitely not happening in Japan, but which may be happening in the other parts of the world. You may ask that why this is so important of the quality control, because for experienced endoscopists, we may already know where to look at. But in fact, if we look at the data, the cancer detection rate is highly correlated with the quality of the EGD. So this is a study from China showing a correlation between the cancer detection rate, or even the early cancer detection rate, and also with the compared with the AI graded score, the result is very obvious. It is highly correlated with the AI graded score in terms of the quality. That means the higher of the AI monitoring score that you get, the higher chance that you can detect a cancer or early cancer, which is very, very logical, which is further proven by two randomized trial, again from the China. So this is the first randomized trial, randomizing around 2,000 patients. So this is the program that they use, trying to, very similar use, trying to match the examination spots and also blind spots. So you can see that with the use of the AI algorithm, the blind spot number can be reduced from around 6 per examination down to 2 per examination. And in return, you can get higher chance of the early gastric neoplasm detection as well. So with the use of the AI, the detection is around 6% compared to 2% in the routine arm. And probably you can get more, will be the high-grade dysplasia or the low-grade dysplasia, which may be rather subtle or small. So this has proven the importance of the quality. And also another more recent randomized trial, this one is mega scale. So the randomization is around 32,000 subjects from 7 hospitals in China. Again, showing very, very similar result. With the AI assistance, the detection rate of the neoplasm is around 2% higher. And in terms of the low-grade, high-grade dysplasia and also cancer, all higher in the AI-assisted group. So basically, the key message here is if we are monitored for our examination quality, we will perform better. So this is the first key message that I want to show. Moving forward, the AI can probably give us more apart from the quality monitoring. And then I will focus on the detection in the coming slides. So we all know that what are the at-risk stomachs? That means those with the atrophic gastritis or IM. And we also very commonly use two classification systems, the Kimura-Takimoto classification for atrophic gastritis, and also the endoscopic grading for IM. So can they be assisted as well? Because they are mostly subjective, or I would say expertise dependent. So can they be standardized as well? So this is a study, although this is just a preclinical study focusing on image analysis, but you can still see that with the computer algorithm, the grading for the EGG-IM score is quite reliable with around 90% accuracy and also 100% specificity. That means no false negatives. This is very important because we all know that for patients with higher EGG-IM or extensive IM, we need to subject them for surveillance. So with this algorithm, we can confidently say that no high-risk patient is missed out. This is very important. But of course, we definitely need a full clinical trial to make sure this is valid in the real-world setting. And apart from at-risk stomach, we also want to detect lesions because after all, the examination is to detect early cancer. So this is an example case that we recently encountered. So this is the white light endoscopy image for a patient's stomach. So if you pay attention, there is a very small depressed area in the antrum. And this patient is also recruited to our recent upper GI AI study using the Olympus OIP GE1 prototype. You can see that the AI can correctly identify the lesion. And if we take a closer look using a magnifying MBI image, we can appreciate the very nice demarcation line and also the central absence of the microvascular microsurface pattern. And the key point here is this AI can work in white light, which is supposedly to be inferior than the MBI, as we just heard about that. So probably this can help us to enhance our detection ability, and then we can also re-examine it using the better quality image to minimize our missed chance. So there's an ongoing pilot study in our center led by Professor Hong-Chi Yip and myself. So this will be a prospective tandem study. So we focus on the high-risk subjects. That means those with family history or history of cancer for surveillance. Then we will examine them with the first pass with standard white light endoscopy. And then the second pass with the AI-assisted examination. And the primary endpoint will be the neoplasm miss rate. So this study is ongoing, but hopefully this can provide a better taste of the accuracy and also the sensitivity of this new AI system developing, actually developed by Professor Ken Xiao first, and then we also work with the Olympus team. But if we look around the world, there are also other AI systems that are developing or even developed. So this is a very large study from the China examining another AI system called EndoAngel. So you can see in this single center tandem randomized trial involving around 2,000 cases, the per lesion miss rate and also the per patient miss rate is dramatically different here. The AI arm has around 20% lower chance of the first pass missing rate. And also the detection rate in the first pass is also higher in the AI arm. So that means that if we look at it in a tandem manner, we probably will pick up more lesions using AI first. So this is a very interesting study. But we also know that tandem study has some inherent limitation. For example, some Hawthorne effect or some uneliminated bias. So to be fair, I think parallel RCT may provide a better overview in terms of the overall effect. So this is a very recent randomized trial published in Gastroenterology from 24 hospitals in China, involving around 30,000 patients. So this is a parallel study. So I think, again, they are examining the EndoAngel system developed in Wuhan. So you can see that this is a one-to-one randomization. And the result is quite interesting because this is quite contradictory with what we just heard from the tandem study. So for this parallel randomized trial, after the central pathology review, the AI-assisted group is not better than the unassisted group. The difference is very, very small, only 0.2% different, even with the AI assistants. So this will raise a very interesting question. that why we can observe the difference in the tandem study, but not in a large-scale parallel randomized trial. And of course, if we even look into the subgroup analysis in this mega trial, we can see that the overall difference is basically very minimal between the two arms. The only positive subgroup here is probably those with very, very low experience in terms of the endoscopy, like within 3 years difference. So probably the major difference may be in those very junior endoscopists in terms of the help of the AI. But still, this is a very, very interesting area that we probably should look into a greater detail between the discrepancy of a tandem study and also the parallel studies. Nevertheless, we will go to the last but not least is the AI-assisted diagnosis, because after all, we need to make correct diagnosis and also with some staging to decide whether the patient is good for ESD. So some preclinical data before summarizing the all the image or video-based analysis show a very, very good performance of the AI-assisted diagnosis with a high sensitivity, high AUROC. And in fact, Professor Kong SAR also tried to develop a AI-assisted magnifying MBI OGD. So this is his latest paper. So his AI system is perfect, 100% sensitivity and 100% specificity compared to all the other expert or non-expert endoscopists. You may notice that the overall specificity is mainly higher in the experts, but not the non-experts. But after all, the preclinical results all show quite promising data. But in terms of the real-world data, this is slightly disappointing because this is the latest published randomized trial from Japan as well. So it is trying to randomize them with the use of the AI algorithm CAT-X to help with the diagnosis between cancer and non-cancer versus the conventional group is by endoscopists. You can see that in both arms, the accuracy, the sensitivity, specificity are not higher than 70%. So basically, there's still a lot of room to improve in terms of the CAT-X algorithm. My view is that basically all the current CAT-X system is rather binary, and probably they cannot consider all the texture and also some morphology, presence of ulceration when compared to the expert endoscopists. We take into account for multiple factors. So definitely we need a better algorithm in terms of the AI-assisted diagnosis, because detection is rather easy. To make the diagnosis, sometimes we need a multifactorial elements to consider. Nevertheless, if we move forward to the future in this field, my personal view is we definitely need a multifunctional platform all in one. So this is actually the EndoAngel system that we tried. So you can see that this system can provide a very comprehensive quality check in terms of the timing and also the blind spot. When you have completed it, the left lower corner will light up, and they will tell you which site have been missed as well. And also, this is the detection system. So when they detect something abnormal, it will prompt you, and then you can then turn into the MBI examination for a better examination, and then they will give you the prediction as well. So this should be the way forward. It's the all-in-one system compared with very fragmented system currently. And last but not least, I think there's a huge unanswered question in terms of the de-skilling problem using the AI as well. So this is a German study using some eye tracker, and it's shown that with the use of the AI, even the experienced endoscopists will be distracted in terms of the eye movement. They will stay very focused in the center, probably is within the alarm box, compared to we will try the normal situation that we will try to scan around. And of course, in the lower GI, this is a very hot study showing the reduction of the ADR after the introduction of AI. Therefore, the risk of de-skilling in endoscopy training is also a very hot debate currently. So to summarize, I try to cover the current landscape of the AI in upper GI. So I think there are a few points that we need to tackle before we can really make good use of this. First of all is how do we resolve the discrepancy between the preclinical and also clinical trials, especially for the computer-aided diagnosis. Excellent result in the preclinical, but rather disappointing in clinical trials. And also, even for the detection system, the major difference between the tandem and parallel studies is also worthwhile to be investigated. And secondly, I think for upper GI, the major limitation will be we lack a good standard or hard clinical endpoint, because we have the adenoma detection rate in the colon, but we don't have something similar in the upper GI. So it will be hard to demonstrate the major benefit in the upper GI. And of course, the lower disease prevalence in terms of the cancer compared to the other pathology, and also very heterogeneous pathology in the upper GI, or a different look of the different types of cancer. This will also make the conduction of a major clinical trial rather challenging as well, with a huge sample size. And last but not least, I think the training issue will be a major point to look at. Finally, I want to conclude it with the WEO position statement recently published in Digestive Endoscopy. So in terms of the computer-aided detection, I think the group also is quite positive in terms of the quality assurance, and also the detection system using the CAT-E system. But when we move forward to the computer-aided diagnosis, the group is not that positive, especially in the point 2.2. You can see that we all remain quite challenging for AI to predict all the very complex tumor characteristics like the size, histology type, the invasion depth. So this will be a lot of work to do. And last but not least, some future research direction. I think the major recommendation will be the cost effectiveness, and also a broader or all-in-one AI-based risk stratification model will be necessary. So with that, I would like to end my talk here, and thank you very much again for the invitation.
Thank you, Louis. A lot happening with AI. I think one thing to learn from your talk is that we cannot get rid of the experts. The experts are the most accurate in making diagnosis, and also
Yes.
not missing out gastric lesions. We are slightly behind time, so may I invite our two experts to comment? First, Professor Louis Lau, how would you do a upper GI examination? And do you have any comments for the two speakers?
Okay, so thank you, James, for inviting me. So first, congratulations, Kadota sensei. I also involved in his study, and then I know he's really, managing the all study, groups. So it's, tremendous effort. So actually, so reason why TXI failed, NBI is better than TXI was probably he also mentioned that NVR uses a narrow banded, very specific light absorbed by the hemoglobin. But the TXI basically uses a white light, conventional white light, and then just enhance the color and texture by computer algorithm. So he mentioned like when I experience usually not only lesion, but also background mucosa, because it uses overall white light. So not only a lesion, but also surrounding inflammation or everything is really enhanced. So I think it's not specifically enhanced the lesion. So that is a difference, one of the difference, I think. And also, another comment is Kadota sensei really mentioned that the esophageal lesion NBI is very good. I really feel such kind of benefit by clinical practice. But when I involved in this study, gastric lesion detection, even when we switch the mode, change the illumination light, I could not really feel it's really significantly benefit or not. So I think still gastric lesion is very difficult because it develops on the background of inflammation. So I think still some limitations. And even though there is some many studies shows benefit of randomized control trial show investigate the difference of image enhanced endoscopy, but most difficult thing is for endoscopy randomized trial, we cannot really mask the method. So it really impact the result in the investigators' intention or unintentional wish or something is really affect. So still, I think benefit of image enhanced endoscopy for early gastric cancer detection has some limitation. So I think most important thing is maybe AI help, but good quality observation, like a good preparation, and then avoiding systematic observation. I think still good quality white light is still standard for early gastric cancer detection in my practice.
James, do you have any comments?
Yeah, I agree with Professor Louis Lau. Okay, so in my mind, I think one of the reasons why a lot of the image enhanced modalities work in the esophagus and the colon is because I think structurally these are tubular organs. So to do a withdrawal with light shining through a straight tube is very easy. But the stomach is very capacious, and to examine, there's a lot of maneuvers involved. And so therefore, the advantage of having image enhancement is lost if there is not a good systematic examination or technique. The other difference between esophagus, colon versus stomach is that the equivalent of gastritis, so in the stomach, the background, there could be gastritis, atrophy, and to varying degrees in different parts. But in the colon and the esophagus, there is no equivalent in a sense that you can't have so the only equivalent is, let's say, IBD. And even in those situations, image enhanced endoscopy and AI don't work the way they're supposed to work. So stomach is really a very difficult and very unique organ where IEE may not necessary. And for upper GI AI, I think the difficulty between upper and lower GI is that in the upper GI, you're really talking about three separate organ systems: the esophagus, the stomach, and the duodenum. Not even speaking about the oropharynx. Whereas in the colon, you're just looking at the colon exclusively, and lesions tend to be polypoidal. So an AI system trained on one organ system versus upper GI when you're doing three organ systems, and you have people tend to do it much quicker. It's very difficult for AI to keep up. And as what Professor Louis has highlighted as well, for lower GI examination, we have quality indices to benchmark against. That's been around, but even up to this day, upper GI indices, no one really knows. Even for something as simple as inspection time, I think the 7 minutes that is often quoted is from the Singapore study. But what people don't talk about is that there is 7 minutes for the entire examination. So the lesions detected were not only gastric lesions, but for like Barrett's esophagus as well. And so a lot of other studies talk about inspection time exclusively for gastric inspection. And so even that time, it's not really, we don't even have anything to benchmark against. And so when we talk about CAQ for AI, very, very difficult because 3 organ systems, no real good quality benchmarks like we have in lower GI examination. Yeah.
Okay. For the participants, you can type your questions and we will try to answer these questions. I think I have a couple questions for Dr. Kadota. In your phase 2 study, do you think the 2% difference between TXI and the NBI, could it occur by chance because you only had about 300 patients? And then moving on to a phase 3 study and dismissing TXI on 600 patients, do you think that this is a little premature?
Thank you for the question. The first question, as you mentioned, I agree with phase 2 study is not the superiority study. So this is an exploratory study. So we have to choose NBI or TXI. So we choose the winner, third generation NBI.
All right. Okay.
Okay.
And then do you think that if you move the trial out of expert centers, would you be reproducing the same results?
It's a very difficult question. And the ongoing phase 3 trial patient institution is bigger to 6 institution to 26 institutions. So this trial will result with answer.
Okay, I think a larger sample size would help to
Yes.
answer the question. But one common observation is if you try to do a larger trial, but a little like the China gastroenterology study, you tend to lose the quality. I think first and foremost is the quality of the endoscopist that mostly determine the outcome. So it's if you do mega trial and slowly you lose the observed benefits. I think the quality control of bigger trials are in fact very difficult.
Yes, yes.
Yes, indeed. Yes. I have one more question for Kadota Sensei. What do you think about the new function of the NBI TXI? The combination, will it be better?
Oh, it's a very difficult question. I think I don't like NBI TXI observation because I can't catch the difference between only NBI and NBI TXI. So I think only NBI is
Good enough.
good enough. Yes.
Understand.
How about you?
I have tried to use it for characterization. I think it will give us a little bit more enhancement in terms of the vascular pattern. But in terms of the detection, I agree with you that I am not very aware of any very major difference. Yeah.
Thank you. Yes.
Yeah.
We have 1 minute left. So just an observation, not an observation. I think this is, I think it's fair to say that artificial intelligence is actually an adjunct to whatever we do.
Yes.
I think the endoscopist, the quality and the quality of observation, even in white light, as Professor Ito correctly pointed out, is the observation is actually very, very important. And all the station-based and also the enhancement and so on and so forth, they are actually adjuncts to whatever we do. So that's my observation. Sorry, there are 2 questions from the audience. I don't see the questions here. Yes.
Yeah.
So there's a question from Dr. Yoshida. In the results of the parallel trials, there was no improvement compared with the group that did not use AI. Do you think the outcome would change if the performance of AI improves? Louis, your answer. Are the performance of AI specific to the AI systems? Like if you have another system, would the results be different, or if you have modern generation system with the different
Yes.
results be
I
very
think this is a very good question, and I think all the AI trials are really system specific. That means it cannot be generalized by in terms of the class. Especially I'm working with in a meta-analysis, network meta-analysis, comparing the lower GI systems. We can observe quite major differences between different systems as well. So I think for AI clinical trials, we cannot generalize from one system to another system. So definitely this is a yes for this question, I think.
But in the future, if you have better systems, the performance would actually change. Oh, yes.
Definitely. The training sets, the algorithms are all different. So
Okay, James would like to take on this question.
Yeah. So one thing we observe is that because the foundation model, once it improves, everything else follows. So I think in the early experience with computer-aided detection for the colon, there were initially a lot of false positives across all platforms and all companies. But the moment the second version came out, you find that no matter which company you're looking at, nowadays there's almost no false positive for the ones available on the market. So again, I agree with Louis that actually if the performance increase, and you'll see it across platforms. That means you see every trial start turning to a certain trend. Before one company then leapfrog, and then everyone else that validates on that company will all follow the same trend. So I think if anything goes, but again, like what we were discussing earlier, the difference is that for gastroscopy, I think it really depends a lot more on the endoscopist maybe than for colonoscopy, just because of the nature of the lesions. So that's the only factor that's probably the unknown. Yeah.
Okay, there's a question from EndoVision, one of the developers for AI. When in clinical trials, and then all the system really perform very well, but when you actually using the AIs in the real world, in the real world setting, what do you consider being the gold standard for validation? And specifically, how do you ensure the system maintains very high accuracy across different clinical settings? It's difficult to maintain the impact. Yeah, anyone would like to take these questions on? That's a very difficult question.
Yeah.
I think most of the clinical trials are performed by experts, and that's why I asked the question: if you perform this trial outside expert centers, and how do you generalize all these systems?
Yeah, I think I agree with James that yeah, I think overall the major benefit observed will be those who are more junior in the AI trials. So that means experts probably are already very experienced and they can detect things. So in the future, probably we should focus on how to standardize on the training with or without AI. And in terms of this question, I think this is what I mentioned in the talk, that for upper GI, this is really difficult because we don't have the hard clinical endpoint like in the colon, like the ADR as the standard quality indicator. So I don't have a very good answer to this question. Maybe for now, most of the trial will just use the cancer detection rate as the endpoint, but considering the low prevalence, it will be translated into a very, very large sample size for clinical trials.
But would you agree if you move these trials outside expert centers, the benefit will slowly be diluted with less experienced people doing endoscopy?
But I think if we are talking about AI, the less experienced endoscopists may actually provide a bigger difference in terms of detection rate. I don't know.
Okay. That's a question for us to think about. Last question before we close. For again, Louis, what are the major causes of lower ADR in AI? Are there any solutions to tackle this? I do not know exactly the context of the question. So major causes of lower ADR. Are we not supposed to improve the ADR with AI? Huh?
I don't understand the question quite clearly.
A few years ago, I was in this ASGE plenary session with the conclusion with a trial from Spain showing no difference with the use of AI, but then they used advanced neoplasm as an outcome endpoint, and they could not show a difference with 600 patients. So yeah, but then and that's why ASGE have not come to support the use of AI in colon examination. But things might have changed. Okay.
Yeah.
All right. So we've had I think we've had a very good session. I certainly enjoy Louis and Dr. Kadota's presentations. And as I said earlier, I continue to admire the multi-center studies performed in Japan, and they are they're very informative. The difficulty with these trials is, of course, the outcome endpoint is usually very small, needing a very large number, and then also with the tandem studies, you tend to have this crossover effect, and at the end of the day, it's kind of difficult to interpret. With that, I thank all the speakers, both speakers and the two panelists, and also the participants for being with us. I like to thank you again. Thank you very much. And then we'll look forward to the next one. Thank you.
Thank you.